We make a start. So hopefully everyone can hear me okay. So good afternoon everyone. Thank you for joining our webinar. We'll be talking about advanced practice in midwifery. So my name is Kashka Richards. I'm one of the project managers in the Faculty of Advanced Practice, and you'll notice likely that we're recording this meeting so we can share it with people that weren't able to attend in person. Hopefully you've seen the programme for the webinar. We've got lots of great presenters with us today, and we've also allowed some time at the end for some question and answers. So if you do have questions, you can put them in the chat box, or at the end you can raise your hand on Teams and we'll come to you. So Katie Cooper, our faculty lead, was meant to be presenting today, but she's poorly, so I'll be doing her slides. So I'll try to do them justice and see if I can go along without any technical difficulties. So just bear with me. Is that working now? Sorry.
Yes.
You can see some slides. Okay, good. Right, good start. So I'm going to start by giving a background and an update on background on advanced practice and an update on regional and national advanced practice developments. These are Katie's slides, so do bear with me. So a bit of background and context to advancing practice to start with. So as some of you will know, advanced practice roles aren't new, and the NHS long-term plan and interim people plan clearly acknowledges how advanced practice roles can significantly help in meeting the short-term and long-term workforce demands and have the ability to drive workforce transformation, agenda forward. The lack of clarity surrounding advanced practice has resulted in lots of confusion to the public, employees, commissioners, and has impacted on the ability to effectively workforce plan. So to overcome these concerns and ensure, to ensure robust future planning and development of these roles, the Advancing Practice Centre was set up. So the Centre for Advancing Practice, a bit more on that, has been developed to oversee the workforce transformation of advanced practice by establishing monitoring standards for education training for these roles, accreditation of programmes and supporting practitioners. So for us as a regional faculty, our main aim is to ensure that advanced practice is embedded as part of workforce planning and is a solution supporting service redesign and change. So this is a definition of advancing practice as it is in the multi-professional framework of advancing practice. So in 2017, NHS England commissioned work specifically looking at defining advanced practice and the core capabilities that anyone with advanced in their title should be able to map against. This was important as it clearly set out organisations and practitioners the minimum capabilities and level of the practice that they need to be working at as an advanced practitioner. And this enables us to develop a workforce that is not only sustainable but has transferable skills regardless of their professional background. So this national definition clearly defines that advanced practice is delivered by experienced healthcare professionals, that it's a level of practice and not a job description, and that it should be underpinned by master level education, and also that it's characterised by breadth of capabilities and competencies, not depth of expertise or specialism. So key principles of advanced practice include safe, effective, autonomous decision making in complex and uncertain situations within the practitioner's own scope of practice. So going forward, all developments of advanced practice frameworks and capabilities will be across these 4 pillars. So a bit more about the 4 pillars of advanced practice. Currently, we're finding that a majority of advanced practice posts that have been created and are in place focus on the expert clinical practice pillar. However, for these roles to be recognised by the Centre Advancing Practice, they will need to demonstrate that they're working across all 4 pillars, as this is in line with new national minimum standards outlined in the multi-professional framework. Also, higher education institutions, which I'll be abbreviating to HEI for now, will need to demonstrate a blended integration of the 4 pillars within their training programmes in order to be accredited by the Centre. So this slide outlines some of the regional developments. So you can see that we've produced a local guidance document around advanced practice training. So it covers things like funding, but also goes into other things like supervision. It's on our regional webpage on the Advanced Practice website. We're also now including our heads and directors of midwifery in our demand scoping process for advanced practice training. That's not something that we did before. And we've also recently appointed a new project manager on our faculty, who is Romy, who's on this webinar, and her portfolio will include a focus on advanced practice in midwifery. There are also some national developments to be aware of. There are maternity credentials in development, and my colleague Sim is on the call, and we'll be talking more about those a bit later on. There's also the national team are looking to go out to tender for HI procurement, and we're anticipating that the criteria in the procurement would be that the HI is offering postgraduate midwifery education. Moving on. So here on this slide, you can see some resources where you can learn more about advanced practice, consultant level practice, and advanced practice in midwifery. My colleague Kenda will be speaking more about the report on the top right. And you can also find lots of resources on our website, which I mentioned earlier. And this last slide is just our contact email, so how to contact our faculty. And we also have a mailing list, which you can sign up to. We send monthly updates. We try not to bombard people, and I can share a link for that afterwards. So hopefully we should be moving on now to Kenda, who hopefully will be able to share their slides.
Thank you, Kashka. Bear with me while I try and get my slides up. It's always that scary moment, isn't there?
Yes.
Yes? No?
Yep, can see them.
Okay, brilliant. So I'm just going to talk to you about a piece of work that we did for HEE in 2020, was published in 2021. The project team at UEA involved my colleagues Helmi and Jane Needham, Ruth Sanders and Georgina Souza, and HEE commissioned us to do some scoping work, a deep dive really into advanced practice in midwifery. And in doing that, initially HEE called for evidence to the maternity services, and they produced from that call some posters and papers about initiatives for training or deploying those with advanced level skills. They also called for job descriptions and narrative role descriptors. We conducted a literature and evidence review, which was really a rapid review of the relevant published evidence around advanced clinical practice in midwifery. There was very little that was specific to midwifery. There were some, and there was a large study in Ireland done around advanced practice in nursing and midwifery that they used to initiate their standards for with their regulator for advanced midwifery practice. So we looked at them. We looked at some of the evidence that they had produced to produce those standards, and we analysed several papers, and there was very little evidence of advanced clinical practice in midwifery. Some consultant practice, lots of variation in that. So then from that we went out to stakeholder engagement, and we spoke to heads of midwifery, directors, other midwifery leaders, to specialist midwives, to those holding ACP contracts or trainees on ACP or consultant midwife programs. And we worked along with the National Steering Group for Advanced Clinical Practice in Midwifery. And then the third stage was mapping. We mapped the Nmc Standards for Midwifery to the Acp Framework. So I'm just going to take you through the findings of really the stakeholder engagement and the mapping for that. So in talking to stakeholders, we talked to 18 Acp midwives, so that was specialist and consultant midwives, 12 senior midwives, HOMs and DOMs and above, and 7 LMEs responded to some email questions put out through the LME network, Lead Midwives for Education network. So the HOMs and DOMs really had very mixed views. They described pretty clearly between them that advanced clinical practice midwives were clinically based midwife with expert knowledge outside of the realm of pre-registration midwifery training. Most agreed that ACP should be or are educated at master's level. Many of them knew about nursing or neonatal advanced practice, but they were mainly of the view that this was not the right model for midwifery. So they gave some evidence about the use of ACP in maternity organisations, and some of the roles that people with that level of practice were fulfilling. And some of those were in relation to complex care, working in collaboration with cardiologists, renal and fetal medicine specialists, running working within multi-professional clinics and supporting women with complex pregnancies. Some were in enhanced maternal care, ACPs working within HDUs and within midwifery teams, some in maternity critical care, some in perinatal mental health. They wanted skill sets that were around non-medical prescribing and ultrasound, but they weren't entirely clear about, some of them weren't entirely clear about what advanced clinical practitioners could do for their programs. But many of them were involved in transforming their services, so they were thinking about how differently services could be delivered. There was data from the advanced practitioners. Clinical research midwives were leading research studies, educating midwives and championing research. So they were very embedded in those education and research pillars. And although they thought, although they described their clinical involvement in the studies, some of them felt that their colleagues were questioning their credentials in relation to clinical skills, although they were leading research. Clinical specialist midwives or advanced practitioners were working in areas in complex ill health, critical and high dependency care, community hubs and triage. In maternal health, around cardiac, neuro, hypertension, learning disability, and some were running triage and antenatal assessment units and using their skills there. The consultant midwives were leading service innovation. They were running birth options clinics for complex care planning, and they were debriefing services. Many of them also were acting up for HOMs, and so there was interesting discussions around the role of the consultant midwife. So role clarity, those who were in roles were very clear about the benefits. So those who held advanced clinical practice status were working at that level of practice, were very clear that they were enhancing the care pathway for women. They were providing a midwife across a whole journey, even if that pregnancy was complex. They were clear that they were not being a substitute or a replacement for a doctor. And I think the multi-professional framework makes it very clear that this is not about medical substitution. And Bev Harden, who worked to develop that framework, is very clear when you talk to her that that is not the view of this. And having access to specialist advice, support and guidance directly was a real key part of that of that level of practice, that you were talking directly to other clinical experts, having direct access to physicians and others at consultant level. And they felt that their work was improving service and care of women and families. So we've already talked about the pillars of advanced practice, so very clearly there. The distinction between consultant and advanced practitioner, we were very interested in that because at the time Kim Manley was working on a consultant framework, which was multi-professional framework. So we're very interested in what the difference with those roles were and how those in those roles could see that. ACPs were more closely aligned to direct clinical practice and patient facing, and they had a higher proportion of the clinical pillar. Those in specialist research posts were more likely to be aligned to research and education pillars, although they also had the other elements of the advanced practice pathway. Consultant midwives were in more strategic and influencing roles, advocating and improving service through leadership, practice development and innovation. They often had very much wider clinical and professional networks, often, as I said, acting up for HOMS, and they had a higher proportion of management and leadership within their role. However, there was generally agreement that all can and do coexist in organizations. So you can have enhanced practitioners, you can have advanced practitioners, and you can have consultant practitioners in midwifery, all in the same organization with mutual respect for their roles. In terms of career pathways, those in the ACP roles that we interviewed, or who were on pathways, trainee pathways, were clear that they wanted career development, but they didn't want that to be on a management pathway. Some of the ACPs had previous nursing knowledge, and they had developed skill in critical care or cardiology or something like that, and they brought that with them into midwifery with a clear view that they wanted to use that for the benefit of pregnant women. However, there were also other ACPs who had no nursing experience and who developed their specialist knowledge through various routes before doing their ACP education master's programs. So some in specialist ACP roles had aspirations to become consultant midwives, though by no means not all. And there is demand for this ACP career development among midwives, but not all HOMs and DOMs really understand the roles or support them. And the midwives who do not have direct access to career pathways are carving out their own, very much like what happened with consultant midwives when they came into being. They were really carving out their own paths. And that's why work really does need to be done on developing career pathways. ACP programs in the trust generally were thought to be not for midwives. So that is, it's interesting to hear what Keshka was saying previously about how they're actually targeting HOMs with information about funding for ACP training now, so that they are really clear that this training is available to midwives. And 5 out of 7 LMEs reported their higher education institution had no ACP program specifically for midwives, and 1 had an ACP apprenticeship program, but no midwives were on it. HOMs and DOMs were concerned, and they were calling for a national steer on advanced clinical practice in midwifery and some sharing of knowledge about what this level of practice could do within maternity services. They were unclear about the career pathway to advanced clinical practice, and they were unclear about the accountability, the level of leadership and the decision making of advanced clinical practitioners. And their questions were around how do they fit within the organisational structure, who line manages them, those types of questions. And there were also budget concerns. Will there be funding for training? Will there be funding for role appointments? And we've certainly seen struggles around this. And where HE have provided pilot funding for training, some trainees were going through the course and then not actually having a role at the end of it within their organisations. So I think we'll be talking a little bit more about that today. So some examples, there were great examples in Cheshire and Merseyside of community hubs supported by ACP developmental roles. Those midwives are going through a master's apprenticeship programme at John Moores. St George's Maternal Health Hub, where there was a consultant midwife and 2 ACPs who was supporting the ACP development. And the Midlands ACP development was being supported by a master's apprenticeship to facilitate complex care, pregnancy assessment and antenatal care. Yeah, the midwives have, looking at the mapping, the NMC proficiency to the ACP frameworks really, and the NMC 2019 standards for midwives says that midwives have the ability to develop in their careers in directions that can include practice education, research management, leadership and policy settings. They continue to develop and refine their knowledge, skills, resourcefulness, flexibility and strength, self-care, critical and strategic thinking. So this says to me, and you know, that there is a trajectory for midwifery to develop beyond the standards set at registration. So we mapped the 2009 and 2019 NMC proficiency standards against the multi-professional ACP framework, and we were looking for evidence of advanced practice skills in midwifery at the point of registration, because there is some thinking that midwifery is advanced. So the NMC standards, the 2009 standards, provide proficiency information that may map onto clinical elements of the ACP framework, though in many areas there's only partial fulfillment. For example, midwifery exemptions rather than full prescribing, and full prescribing requires a significant skills in assessment and diagnosis, which isn't set within the NMC standards of 2009. And there were significant gaps around leadership and management education and research. And in the 2019 standards, clinical areas where there was disparity between midwifery standards and the ACP was in the exercise of professional judgment, the idea of supporting teams to do that, and the working collaboratively across organisations and settings, and being able to act as a clinical role model, informed by an understanding of local population, health needs and agencies and networks. So some of these midwives are going some way towards the clinical standards, but there is still some shortfall against the ACP standards. And in the leadership and management, we rated them red, amber and green, green being that they met fully the ACP standards, amber being ambiguous and red not meeting them. So in the leadership and management, there were a number of areas which were ambiguous and likely not to be fulfilled. And in education, there were 3 green areas only, and the rest were red, and in relation to research was mainly not met. So the key points really from our report were that multi-professional advanced clinical practice framework describes a level of practice, and it's very important to understand that. The lack of information for midwifery leaders is a potential barrier to development of the ACP in midwifery, and midwives are seeking out opportunities to become advanced clinical practitioners. And mapping of the NMC proficiencies against the ACP framework shows that it would be inaccurate to describe newly qualified midwives as advanced clinical practitioners. So the ongoing work, and others will talk about this today, is happening around the development of an ACP Capability Framework for midwifery specifically, and we're doing some work on that at UEA. and we're running some workshops. The next workshop will be the 10th of March, and I will leave some information with Kashka to distribute to the attendees here today if anybody wants to join that workshop to help us with the development of that capability framework on the 10th of March. And then we're also going to be working on developing an education and career pathway document, which will hopefully be ready by the end of the year. The report can be accessed online, and it was really great to do this work, and I wish to thank all the midwives who contributed and gave us into such insight into the current thinking and all of the lovely innovations that are going on across the country. Thank you very much.
Thank you ever so much for that, Kendra. That was really good. That was really interesting. I think we now have Simma. Apologies if I'm pronouncing your name wrong.
It's absolutely fine. You have pronounced it right.
Oh, good. Oh, good. Okay.
Thank you. So I'm going to share my slides, and again, hopefully it will happen. Can you see that?
Not just yet.
Oh. So let's have another.
Yep, I can see some slides.
Great, thank you. So let me put it on the slideshow. Okay, so I'm actually representing Health Education England. I've only been around 3 or 4 months, so I'm really presenting this on behalf of Sally Ashton May and the great work that is University of East Anglia has done with Kendra. So a lot of has already been said in terms of advanced clinical practice. As there was a fantastic definition earlier by Kashka, so this is really saying the same thing and talking about the advanced clinical practice with the 4 pillars of clinical practice: leadership, management, education and research. And as has already been said, ACP has the MSc degree apprenticeship, typically 3 years, and these are practitioners who will work with high degree of autonomy and complex decision making. I won't go through it again because I know we've had this already. And again, in terms of what advanced practice is, the centre talks about having a standardised and structured unit of assessment and helping with workforce development in areas of high priority, and that these group of practitioners would have high level of capability and capacity. We are not at the moment, we've been asked rather not to call it credentials, and that's being discussed at the moment, and we will confirm what we would call it, perhaps capabilities or capacity capability or competencies, but it's an issue around it being multi-professional credentials, so just bear that in mind. The context again has been talked about already, around it being a high priority for NHS strategy, both in NHS long-term plan and the People's Plan, talking about different models and delivering care differently. And as was said again, the maternity programme at HEE commissioned University of East Anglia to look at this issue and map the workforce and come up with some, doing a deep dive into the issue of ACP, and Kendra has delivered that in terms of recommendation much better than I'll ever do. But basically, there was a lot of confusion about what ACP is, different levels of practice. So we're really now going to start looking at development of an education and career pathway, and alongside the ACP framework. I'm galloping through this because a lot of has already been said. So we want to really create a transferable, recognisable, ongoing ACP education and training, because failure to create a ACP competency will, against all 4 pillars of the ACP, will not really lend itself to looking at current and future midwifery provision. And we to articulate their capabilities for the current and future workforce of these new models of care. Work has already started, as Kendra was saying, that the University of East Anglia has already been commissioned to develop the ACP midwifery competency, and we've started having our first meeting, and we're looking at the competencies which is in development. There's also work that's going on around nationally for future midwife, future nurse, for the education career framework, which this would fit into. What else can I tell you? Yes, the work will aim to finish in May. So then HE plans to pilot the competencies in September, and the universities delivering the pilot cohort will be confirmed later date. At the moment, we've got a list of universities who do deliver midwifery at MSc postgraduate level, so we would take that from those universities. So the pilot cohort will be nationally, and there'll be 40 ACP places starting hopefully in September 2022. The places are part of METIP, so and they're not assigned to any region, so there's no nothing new in that METIP. These are included in METIP numbers, and the services within the region are asked. Really, the key points are that these posts should be supernumerary band 7 posts for these trainees, for ACP trainees, and they should have appropriate supervision to support trainees while they're on their program, and that at the end they should have a suitable ACP job description and an 8A post ready for them. This is a sort of estimated timescales that just kind of visually to look at. So we are at quarter 4 of 2021-24 at the bottom blue, second blue box that says we've started development of the competency work with task and finish groups, and then quarter 1 being May. Hopefully we will have the midwifery competency work completed, and then go on for September in terms of the 40 places, and then going on getting the accreditation of the credentials of capability competencies by the Centre for Advanced Practice. So I'm sorry, it's a real gallop through this. But a lot had already been covered by colleagues, so I just thought I'll give you a quick summary. Thank you.
Thank you so much for that, Sima. So next we have Antonio. He's going to be given a case study of his role. Hopefully he can talk and share his slides.
Thank you very much and good afternoon. Let me try my best. Bear with me a second. Right, can you confirm you can see the slides?
Yes, yes, can.
Okay, fantastic. Good afternoon, everyone. I hope that you're having a good day. So I'm here to talk to you about my career pathway. So my name is Antonio Sierra, and I am a consultant midwife, focusing mostly on midwifery-led care pathways, but also supporting the senior midwifery team at my trust. And I currently work at West Hertfordshire Hospitals NHS Trust. so based at Watford. So there'll be loads of midwives and midwifery managers, hopefully leaders as well, educators, wondering, you know, what will be what this talk will be all about. And I'm just one of those midwives that always felt passionate about advanced practice, and always great to hear that we now have a framework and that there'll be pilots taking place, which is fascinating, and I cannot wait to see the future of it all. I'm also one of those people that wanted to progress in their career, and there wasn't really a standardized formal pathway in order for me to either achieve advanced practice or to ultimately reach my goal of becoming a consultant midwife, you know, at the end of it all. So I just want to talk to you about my journey, and the only reason why I want to do that is because I think there'll be loads of you that have already done a lot of work, and you're probably wondering, how will this new program fit in within your working lives, your personal lives, and all of that. All that you've done is not going to go to waste. It's going to help you progress through this, but it's great to know that there is now a framework to support these programs, you know, from a health education institution point of view, and also that there'll be national recognition. So let's see if this, you know, if this is helpful to you. So just going to talk about my early career, different midwifery roles that I have been doing over the years, and then the role of a consultant midwife. So I know that we've heard about the 4 domains of advanced practice, but I'm going to talk to you about a 5th one that I incorporate in practice, and you will all hear about very soon. And then I'll just give you an example of what a week in the life of a consultant midwife is. Now, this will be a difficult job because every week is different depending on what we're focusing on, but I'll do my best. And then also talk to you about my future aspirations. So as many of you will have done in my early career, I completed a Bachelor in Health and Environmental Sciences. This was just for me to gain a holistic understanding of health and environment, really. That's what I felt passionate about. But this is the European equivalent to A-levels. So it won't take you long to realize that this accent is not very British. So I am originally from Spain, did a nursing degree back home, and then moved to the UK to work as a nurse. But ultimately, it was always my ambition to complete a midwifery program. I blame my mother. She's always talked about midwives at home. She's not a midwife herself, but she, I thank my mother, should I say. She was really the inspiration for me. So I'm relocated to South Wales, coming from the south of Spain, worked as a healthcare assistant until I was able to register as a nurse, and then did stroke nursing and rehabilitation for a couple of years until I managed to get a place in a midwifery school. So studied at University of West London. I did a free allocation placement in China, actually, in an American hospital. I wanted to know a bit more about complementary therapies, but also how the Western world have impacted the eastern parts of the world. I've always been really passionate about advocating for the vulnerable and being the voice of the unheard. So this is what really led me to want to become a consultant midwife, to just help those who didn't really feel that they had a voice, to have one, really. So and nowadays still as passionate as ever about vulnerable groups and ethnic minorities. So when it comes to midwifery roles, I've done a number of things. So as everyone else in the call, with a midwifery background, completed a rotational post, including antenatal, interpartum, and postnatal care. And after basing myself in a midwifery-led unit, I then became a Band 7 midwifery coordinator, which gave me the best of both worlds, really, having a bit of management and also, being able to care for women and birthing people throughout their journey. At some point, I applied for a specialist role in clinical education, and this is probably one of the best jobs that I've ever done. Practice development midwife, you really get a good insight into what some of the issues in practice are and how you can help people thrive, really. I've had the pleasure of supporting people going through NMC referrals and local investigations, but equally important, have an impact in making sure that we have a voice with regards to service development and redesign. So that was really good. After then, I applied for my first managerial role. I felt that it was important for me to have a bit of management background before applying for a consultant midwife post. You don't have to do that. You don't really need to have a managerial background. And I have met amazing and super competent colleagues that went straight from a band 7 specialist role onto consultancy, and they are doing really, really well. But for me, it was important to just go through that journey nice and smoothly. So this really gives you an insight onto, what the national pressures are when it comes to health education, and also to have an opportunity to liaise with health education institutions. Also, having a bit of management and on-call experience is always helpful, but also to gain an understanding about finance and budget. And then finally, managed to apply for a consultant midwife post, and this is where I am, and I am really, really pleased with the role. Although, as everybody else, always looking for challenges and new developments. So the role of the consultant midwife, when we look at the history, it was first spoken about, formally written about in 1999, Department of Health, in their document Making a Difference, Strengthening the Nursing and Midwifery Contribution to Healthcare. And since then, we haven't really stopped talking about the impact that we can have in practice, supporting staff, developing services, our contribution to research, more of that. Safer childbirth from the RCOG and RCM in 2007, as well as UK policy back in 2000. Just loads of documents highlighting the importance of what we do. So in order for me to become a consultant midwife, I had two different options: either to look for a HEE training hospital. Unfortunately, this pathway was only very limited and available to a section of the country, and I just did not manage to get into one of their training programs. And hopefully this is something that can change in the future, but at this moment in time, we just don't have consistency throughout the different regions in the country. So what I did is I literally just found an example of a training program and tried to work my way through. So I looked at desirable and essential things, or that were expected on anyone applying for a consultant midwife post. And I tried to tick the boxes, and I went along, and I did that for a number of years. So 5 main pillars. So I'm going to talk to you about clinical pillar, education, research, leadership, and then finally consultancy, which is linked to clinical expertise anyway. So when it comes to the clinical expert practice part of the role, it involves a number of things. So I think that what's really important is that if you're considering this career pathway, that you expose yourself to all midwifery environments, including high dependency if you can, or even A&E, which I did as a nurse in the past as well. This will enhance your credibility and also your competence in all of those different areas. My current area of expertise is birth after cesarean section. I wrote down VBAC, but I call these sessions, back, because we truly advocate choice in these clinics. Also, elective cesarean section for maternal request, birth options in general. So what we do is we talk to mums and birthing people about mode of birth and place of birth, mostly in these clinics. But I've also developed a bit of expertise in bridge teaching just after completing a research in this specific area. We're also there to offer clinical support when escalation triggers. Facilitation of midwifery-led care pathways is really the key part of my role. When it comes to education and professional development, it was really good that I previously had exposure to PDM as a role that I did, and also lead midwifery education, because it just really brings a lot of different layers into your knowledge, and you learn to develop that further. So this is what I have expertise on. So I'm a member of the NLS faculty at the Trust after having gone through the training. I completed a midwifery supervision. I'm currently a PMA, and I also completed masters in midwifery and also a PG cert in midwifery education. You don't have to have a PG cert, but once again, I feel really passionate about clinical teaching, and this is why I went for it. I'm also part of the human factors and physiological CTG faculty as a trainer. NDT training is part of what we do as well, and I have a contract as a visiting lecturer at the University of Hertfordshire too. So service development, research and evaluation, I successfully implemented a bridge clinic with help from a consultant midwife when I was PTM at a previous trust. And this was after completing a phenomenological qualitative study that it can be found in that link. It was published in the British Journal of Midwifery as well, so you can have access to that. We did service evaluation and then an implementation of a clinic, which was really good. It helped communication and it also helped improve the external conversion rates when the midwives, i.e. myself and the consultant midwife, were performing this. Since then, we have led on implementation of other projects, and I am also an aspiring PhD candidate if I find the time to do that. When it comes to clinical and professional leadership, so we've talked about eoeap pathways already, but equally important, we support directors of midwifery, heads of midwifery and risk and governance teams in the implementation and achievement of key performance indicators to do with anything that is hot in the agenda, such as better births right now, for example, or the SAP reports that we've recently heard about, i.e. the documentary that we had last night regarding Ockenden. So we are always striving to help midwives in practice and help service development. I'm also part of the midwifery team, as I said to you, also a PMA, and then part of the East of England's clinical network. And finally, consultancy. So the pillar of the advanced practice role, review of urgent clinical cases and support midwives, women, birthing people, obstetrician, or anybody else in practice. A specialist area in physiological births or midwifery pathways. And then when escalation triggers, then we are also there for on-call duty. So I know that we've got limitations with regards to time, but this document can be found in the RCM website, and it just gives you an oversight of how many consultant midwives we have in practice, just waiting for the latest publication really, but it also provides an insight into demographics and where we're based, and gender, and what type of role we hold. Is it a single post or do we have multiple posts and things like that, and then level of dedication as well. So a week in the life of a consultant midwife, again, varies very much, but generally speaking, Mondays are my managerial and leadership day when I can. Tuesdays mostly clinical. This is when we run our clinics, and I am very lucky to have support from clinical staff in running these clinics. Wednesdays is usually innovation, so quality improvement, service development. Thursdays is my research day, and then a Friday clinical teaching, but I may have on-call commitments on Saturday or Sunday. So my future aspirations, I've got many of them, but hopefully helping enhance pathways of care. And we've got a number of QA projects ongoing. When it comes to research, I'm trying to apply for NIHR funding. That is an application in progress, and I don't know if I'll manage to get it in by this year or next year. But I'm really interested, as I said to you, to look at inequalities in health, and I'm currently looking at trans pregnancies and health. So you would have noted that when I use a language, I like making use of inclusive language, because it's not just women that we are caring for, but birthing people as well, including trans and non-binary people. So when it comes to education, completed an integrated clinical academic career program with a health education in England, and hoping to achieve a PhD in the future. And then personal aspirations, I'm really looking forward to having some time off. So today is the beginning of an annual leave, and I cannot wait to have some time to rest. Finally, obviously quoting the one and only Barack Obama. This is something that he has said in many conferences, and it's just to empower you to actually have the courage to change your life, to have the courage to change midwifery and help us move forward. In the light of the documentary from yesterday, I'm sure that many of us are feeling a little bit down, but we know that we are here to make a positive difference, and we also know that midwives, through training, practice, and with the right support, can only help save lives. So that is it from me, and I'll be here at the end of it all to answer any questions you may have.
Thank you. That was brilliant. Fantastic. So hopefully we have Melanie with us next. hopefully she can talk and share her presentation. Well, I'll be sharing the presentation at least for that, but hopefully she can talk.
Can you hear me?
Fantastic. Okay.
Yeah.
So just give me a moment. I'll share your slides.
Hi everyone, I'm Mel Durkin. I'm an advanced midwife practitioner at Bolton in the northwest. So I'll go on to the next slide, Casca, please. So how and why did I become an advanced practitioner? I was a registered nurse who from 96 to 99 decided to become a midwife, qualified in 2000, was a midwife who rotated across the unit in all different settings for about 12 years, and then decided the opportunity came up to be an advanced midwife practitioner, which is something that I've always aspired to be. The timing wasn't great, seeing as I had a 9-month-old baby and a 4-year-old, but the opportunity was there and I had to take it, and that's what I did. I applied for the post and was obviously successful. I chose a career in advanced practice because I wanted to develop as a midwife. However, I didn't want to take the operational route, and therefore being an advanced practitioner allowed me to progress my career clinic with a clinical focus. Obviously my job is to provide any risk pregnancy care, but with a midwifery philosophy, and that's what really inspired me really to be an AMP. Obviously as a midwife we specialists in normality, but as an AMP I'm obviously allowed to provide care in the high risk and low risk setting, but whatever risk the pregnancy is, obviously it's always with a midwifery philosophy. I wanted to develop my scope of practice and my skills across the traditional professional boundaries, and to make a difference to service user experience and to staff experience of midwifery, and just give a different slant to the sort of traditional operational route that we use to progress our careers in. The next slide, please. So how did the role come about? Obviously 12 years ago advanced practice wasn't a common role within midwifery at all. The role was supported by the head of midwifery at the time, and obviously being in the role, the support from the head of midwifery is a vital element of the role being successful, because you definitely need the support of the head of midwifery in sort of taking the role forward. A business case was submitted for 5 of us, for 5 posts via the Northwest Business Hub, and the interview took place. The head of midwifery, the University of Salford, the delivery suite matrons and the current AMP in post were present. Obviously on appointment we were allocated a medical supervisor who was a consultant obstetrician, and also an academic supervisor from the university. We all undertook a 2-year MSc advanced practice in social care, and we were clinically practice competency assessed using OSAPs, which the GMC use, and obviously following the MSc advanced practice portfolio, which incorporates the elements of advanced practice. Next please, Casca. So the impact of the AMP on patient experience, I find that we're able to meet the service user needs in a very timely manner. We can provide continuity, which is obviously a massive part of the national maternity agenda. We provide a seamless service to the women. We are all non-medical prescribers as well, so we can see the women from the start of the journey right through to the end of the journey, obviously incorporating medical assistance as necessary. It can avoid unnecessary referral and enhance capacity, productivity and efficiency within the multidisciplinary team. Obviously, like I've said, a major part of our role is that even though we do venture into the high risk pathways, we can always deliver care utilising a midwifery philosophy, which is key in patient experience and patient satisfaction, and that's been shown by the feedback that we have received as a team. Next one please, Kashka. So our responsibilities at Bolton, obviously the AMP role is absolutely vast. It's under a very big umbrella, depending on where you work. There obviously are elements that we all follow, but the role is sort of individualised to the trust that you work within, depending on the support that you've got and the job description that you work within. A massive sort of part of the role is clinical leadership and service development, being involved in guideline, evidence-based practice, service innovation, audits, governance reports, serious incidents, supporting staff, providing guidance to medics and midwives. Within our role, we work in maternity triage and provide comprehensive and highly complex and specialised assessments of patients. We're able to autonomously diagnose, plan, treat and evaluate care according to the evidence-based practice and changing needs of the patients. We can provide safe time of practice at advanced midwifery level. We support the MDT from a very different number of perspectives. We're always advocating for women and families. We provide midwifery and medical education within the trust and into higher education institutes and nationally. We published in Midders in 2014 about the impact of advanced practice and challenges that we faced as a group of 5, being probably one of the first teams in the country at the time. We provide high-risk interventions, but again, utilising midwifery philosophy and approach to care. We don't do fetal blood samplings anymore at the trust that we work with because we utilise the physiological interpretation of CTGs. But we do perform Kiwi deliveries, which is the Von2's Omnicup deliveries, within our role as obviously AMPs, which allows us to assess the lady, look at the CTG. If we feel obviously delivery is indicated, we can obviously go ahead and provide that as well. So it's a start to finish service that we are able to provide. The next slide, please. So obviously we practice within the 4 pillars of advanced practice. I've broken it down as to obviously what we do at, well, what I do at Bolton. The 4 pillars are clinical leadership, education and research. In Bolton, we are currently, the AMPs are a lead for maternity triage. Maternity triage is an area that sometimes it's difficult to get medical review, and therefore with the AMPs being in triage, we're able to provide a timely review for the ladies and the families. We also are clinical leads on central delivery suite, being inclusive in the ward rounds, interventions, preventing interventions, and obviously contributing to plans of care for the women. We also always maintaining the obviously woman focused care. And we're also clinical experts in other areas of maternity services, be it antenatal, postnatal, day unit care as well. Our leadership qualities, we are CTG and OASI champions within the trust. We implement service improvement and we network and collaborate with regional and national stakeholders. Within education, we are all prompt trainers and we educate within the MDT and present at higher education institutes and conferences, obviously out of the trust and nationally and locally. Research, we formulate evidence-based clinical guidelines, perform audits, act on audits, and data analyse and outcome and measure outcomes within obviously our own areas. Next one, please. Where am I and where we're going now? We obviously, since qualifying, we've obviously done a lot of things. We've all completed our non-medical prescriber V300 in 2017, which again adds to the seamless care that we can provide to women and families. We unfortunately underwent a consultation in 2019, which the trust initiated to actually remove the role from practice. However, being strong individuals, we fought the consultation and did an extremely good counter proposal with immense support from the medical and midwifery and external agencies, and were successful in keeping the role. But unfortunately, this has led to 2 of the team now leaving, so we are down now to a team of 3. We were then redeployed into triage as leads in triage, which was beneficial to the ladies, but obviously it minimised our input around the unit because we were in triage a lot. However, during this time we have introduced new pathways into triage to improve patient care. But following the consultation, personally, it made me review my own career pathway, and I am now currently the interim midwifery matron for outpatients. This has allowed me to explore my career progression even further. I don't really know what I'm going to do next, in all honesty, but I have obviously just recently again started a leadership programme which will help whether I stay in advanced practice or I move on to operational strategic management. Is there any questions? Sorry if that was very quick. Some questions. Oh, I can't see who's asking any questions. I know people are. Does anyone want to ask anything?
I think we're just giving you applause, Melanie. Well done.
Thank you.
If anyone,
Melanie, I would like, if I've got a kind of couple of seconds, just to invite you to join our workshop on the capability framework, because you've got a lovely clear-sighted view of advanced practice, and it would be really great to have you be part of that workshop.
Yeah,
So
sure.
contact me for details. I've put my email into the chat.
Oh, thank you.
thank you ever so much for that, Melanie. That was fantastic. We've got a final presentation around organisational next steps, and then we can have some question and answer at the end. So start thinking of your questions. So bear with me. I need to share another slide. So please do let me know. Can you see slides?
Yes, they're up, Kashka.
Oh, thank goodness, thank goodness. Okay, so so this is going to be about organisational next steps for organisations that want to develop these roles. So first thing, governance. So as a minimum, governance for these roles. So for governance for these roles, there should be a governance framework in place, and these frameworks should be supported at board level. So this slide here outlines what that framework should evidence. And as a faculty, we are working with organisations to ensure that there is appropriate level of governance in place for these roles, and the frameworks are developed and embedded internally. It's also really important that heads and directors of midwifery are part of these discussions, and we are developing governance templates to support this process. One of the ways that organisations can improve the leadership and governance around these roles is putting in place advanced practice leads. We do have some organisations in the region currently that have put those roles in place. And another way to another governance mechanism is setting up advanced practice oversight groups. And again, we do already have some organisations locally that have set those up or are setting them up. So continuing on what good governance looks like for these roles, it's about ensuring advanced and consultant practitioners feel safe to practice to their full capability and are only limited by their professional registration and scope of practice. And an organisation should also be taking appropriate steps to ensure patient safety. Recruitment and training to these roles should be consistent and equitable, and training and assessment for the roles should be supported and resourced by the employer. Practitioners should be supported to follow national, regional recognition, credentialing or accreditation. So regarding recognition, practitioners can be recognised by the Centre of Advanced Practice via two methods currently, which is successfully completing a HE accredited advanced practice training programme. And then there's also the e-portfolio route. So applications for the first cohort of the supported e-portfolio route now closed, but we are hoping to have a second cohort in this year. So some further points on good governance. There should be robust organisation governance for clinical supervision, and there is HE national guidance in place for this, which we'll come back to a bit later. Ensuring continual professional development for these roles will help retention and will also further increase the level of care these practitioners can provide. There also needs to be a feedback mechanism in place to evaluate how these roles are impacting service provision, access, patient outcomes, pathways, and the teams that they're working in. So this slide illustrates all the reasons why good governance is required for these roles. I can share these slides after this, so you can look at these in a bit more detail. So when we're looking at governance for these roles at a divisional departmental level, there are some key areas organisations need to consider for their current workforce. So needing to ensure that current advanced and consultant level practitioners map against the multi-professional framework, and that we're identifying any additional learning that may be required for them. A job plan, scope of practice and competency should be agreed, and an appropriate action plan put in place to enable recognition and ensure there is safe practice. So when looking at developing new training posts, organisations should be ensuring the new role is underpinned by a business case. That's really key. And this business case should outline the workforce planning behind the role, what the costs are for the training, what the supervision requirements are, and what CPD, so continued professional development, will be required. And it should also allow for the practitioner to transition to a qualified post once they complete their training. We'd really suggest that you link in with your workforce planning teams and business intelligence teams who can help you develop business case. There should also be a detailed job description that maps across the 4 pillars that we've already talked about. We've created a template job description which you can use, which can be found as an appendix in the regional guidance document that I've talked about that's on our webpage. There also needs to be predetermined job plans in place that reflect the 4 pillars and a clear scope of practice with training pathways and competencies defined. So this slide summarises the funding models that HE East of England in particular offer for advanced practice training. You can find more details about this again in the local guidance document. But just to summarise, so one of the models we offer is a £6,000 training grant per year per learner for 3 years. And that's for those undertaking a full advanced practice MSc. So 2,600 of that money needs to be put aside each year specifically for supervision. We also support practitioners who might have enough prior, they don't have an MSc, but they have enough prior learning experience to top up to an advanced practice MSc, and that funding is for a maximum of 100 credits. There's also the portfolio route that's already been mentioned, and as I mentioned before, we've had the first cohort for the supported route. Applications for that have now closed, but we hope to run a second one this year. So this demonstrates how there are numerous potential and established roles that have been identified with the Advanced Practice Midwifery report. And again, I'll share these slides so you can look at this in more detail. Just a quick point on the HE Star online directory, if you've not heard of it. So HE has developed this as a simple but effective model to support workforce transformation. It enables those responsible for delivering healthcare services to explore workforce challenges in more detail, and it develops bespoke action plans to address them. So thinking about your business cases potentially. Multiple resources are already available on this tool, specifically for maternity, and this includes new roles, new ways of working and leadership. So this is just a reminder of our contact details and that we have a mailing list. So I think we're now moving on to Q&A. Let's stop sharing my screen. Okay. So you'll have your microphones and muted, but if you do want to speak, you can raise your hand, or if you've got a question, you can put it in the chat box.
Kashka, there was a question from Mary, and I'm not sure if this was directed to Melanie, but the question is, how would you like to support fetal monitoring lead post?
Melanie, would you be able to answer that?
Yeah, that would be fine. If you want to email me, we can discuss further. That's absolutely fine. I'd be happy to do that. Can you hear me?
Yes, Mary said yes. She said great, thanks. Any more questions? Anyone want to raise their hand and ask a question? We've got Marie. Just need to make sure you can actually talk, Marie, because I don't know if your microphone's been enabled. Hopefully you should be able to use your microphone now.
I can see it now. Hopefully you can hear me.
Yes.
Hi everyone. So I'm listening in. I actually work within the workforce transformation team within HEE. So I've snuck onto this call because I've got a bit of an interest in education transformation. That's my sort of portfolio specifically. But Kashka, it's just to extend an offer really from picking up on your point about the HE Star. Myself and my team are more than happy to facilitate HE Star workshops. So if you've got a specific workforce challenge, we can support you to work through some of that using the STAR methodology. So I just wanted to extend that offer, and if anyone would like to take it up, then please do feel free to reach out to either myself or within the team. I'll put our generic team inbox email address in the chat. So just wanted to pick up on that really.
Brilliant. Thank you ever so much for that offer, Marie. See if there's any questions. We've got some thank yous. So we don't have any questions. Oh, then I've put the our generic inbox in the presentation slides, but we'll also send an email with the contact details and links that we've mentioned. The presentations, I can share our presentations, but if any of the presenters want to share those as well, I can share those, and there'll also be a feedback form as well that we are going to share. But if we have no questions, then I'll give you 10 minutes of your time back, and hopefully you can have a cup of tea, which I'm sure is much needed. Any final offers? Oh, no. Okay, thank you everyone for your time. Thank you very much to the presenters as well. I hope you found this useful, and yes, we'll send an email with some resources and attachments afterwards. So thank you all, and have a good afternoon.
Thank you.
Thank you,
Thanks
everyone.
everyone. Bye bye.
Bye.
Thank you.
Thanks everyone for attending. Thank you.
Thank you.